which stands, one nation, under God, indivisible, with liberty and justice for all.
Okay. Public comment? No public comment. We have the consent agenda. Did everybody have a chance to look at the minutes of the previous meeting?
I so move that we accept the consent agenda.
Sorry. Been moved and seconded to approve the consent agenda as presented. All those in favor?
Aye.
Passes unanimously. I like the thank you letters too. It kind of brightens up the.
Yeah, we haven't had some for a little while, so it's kind of nice to get a bunch at one time.
Okay. So now Ed, the reason you're here on the overtime is you get to do the financial report.
Awesome. I have too many slides, so I'll try to go through it. I just try to drill down in some more detail on the questions that were asked, basically, in prior reports. So this is for August 2021. Start off with the patient count for acute in 2020. Oh, yeah, that is tough. It looks so good on my screen, and then we put it on the big screen. It's a lot tougher.
I got my glasses on.
No, just put my glasses on. So.
Okay.
All right.
Trying. Ken, can you see it? Not this way.
You have to put your glasses on.
No, these are just reading glasses for up front. Would you prefer that we put it up?
On
If
the
that's
projector?
too difficult, we can put it on the projector.
You can come sit right here if you'd like.
I'll sit down.
Whoa.
So for acute in 2022 is 297. It's an increase of 5 over the previous year. Clinics 22 is 2206, an increase of 303 over the previous year. Other outpatient services in 2022 is 5,785. It's an increase of 847.
It's quite an increase, yeah.
Overall, for the month of August, there was 8,288 visits, an increase of 1,155 over the previous year. Next slide.
Is that because we're not a COVID year?
Yeah, I think, yeah,
We are COVID here.
Well, we are,
But not as severe as
not for the panic year.
yes.
Well, keep in mind that when we first shut down in March, it was because of an attempt to try and keep everyone safe.
And the curve.
That occurred. So then what happened was people were fearful to come back to the hospital.
It was a 6 weeks for the
Nobody really understood, but it was the best understanding at that time. So now what we have is people are not as afraid. It's still inconvenient to wear masks and be screened and that sort of thing. But more and more people are comfortable coming back to the hospital. And we have not stopped doing elective procedures.
Probably some little bit of rebound.
But the question I have, it's 1,000 over what it was a year ago when it was at the bottom. Is it back up pretty much on track what it was 2 years ago before we went down?
So there's a couple things to answer with that. And I'll take my mask off so you can hear better. Some of it is we've added new services, so it's hard to compare whether or not the new level is because of new service or expanded. It's really hard to say what is that level. And that's why, to answer that, I don't know the answer.
Thank you.
Gross patient, gross patient charges for July was 4.2 million, increase of 370,000 over the last August. If you look at it trending, year over year out in the right direction. The next part of that is to collect it. So collections for August were 3.05 million, an increase over last August of 1.2 million. It should be noted that prior to the adjustment, the cash collection, there was no adjustment. Cash collections in September are 3.35 million, so it's even gone up since then. So that the efforts are paying off here. pretty significant. It should end up at 10 million higher collections than it was the previous year. I mean, which would work well for the budget. Days cash on hand, for August had cash at 88 days, 12 more than this time in 2020, but still below where we're trying to be with our goals, so. That'll change in, the month of September. Now, this is just July and August, so there's not a whole lot to compare. There's 4.2 million in gross revenue, less the revenue deductions of 1 million, which is about 190K was admin write-offs from the prior system that were past timely filing. And just to be clear on that, even though we write them off, we still print and send the claims and then appeal them. You know, we don't just, we're not gonna work that, we do send them. It's just, the likelihood of collecting is pretty slim. So, let's see. I had notes from the previous month carrying over here to ignore this. Through August year to date, total revenue is 5.7 million, less operating expenses of 6.6 million, less non-operating expense revenue of 14K, produced a net deficit of 679. And I'm going to show you in a later slide what the 679 is made up of. Here's a net margin one I put in there just so that you guys can see that the trend year over year is pretty similar in the first 2 months out of the gate.
Well, we had a bad July. So,
Yeah, I mean, it looks like it's been bad the last several years, so. Yeah. We're gonna iron that out. On the 6-month trend, it's averaging about 3.2 million in revenue and 3.1 in expenses when you take out all the noise. And would be a positive 232.
What do you consider noise?
The one-offs, the grant stuff, the write-offs, you know, the, any kind of take-backs or anything like that don't normally occur.
typically 1 month is just a short picture. I like to see the longer, because from 1 month to the next, you can have, like you said, write-offs or big grant come in. The longer term gives you the better view.
Another example of the variability is if we look at our pharmacy costs. If we have a significant number of patients taking a lot of expensive cancer medication, that can skew our costs and our revenue. If they get that for a short bit and then they're done, the next month we're not providing. So there, you do want to look at a little bit more trends.
That's the adjustment trends. I know there's a lot of questions about this one. I keep telling you, oh, we got this write-off because of this and that. And so I kind of try to break it down into several different categories. So the gross charges you see across the very top there in gray, those are fairly consistent. Just for example, if you look at August 21, 4.2, and then you go back, August 20, 3.8, that's kind of about the same. And then July's are identical. Both July 20 and July 21 are identical. You know, so there's some trends there, and that's, you know, it has a lot to do with business days in the month and all that. So the next one down is contractual adjustments. They're fairly consistent overall, other than you guys see the one peak there. That's the orange line. Next one down is charity care. So that's you know, for folks that don't have the ability to pay. And that's pretty fairly consistent except for that 1 month. And
Well, contractual adjustments are when the cost report comes in, right?
partially is the negotiated contracts, like say Blue Cross or something. Well, they're going to pay 80% of what we charge or something like that, or whatever. That's good.
If you look at over time, our contractual adjustment per month is running about 22% correct. So anytime we have variability in that number, it's something has, either we had an adjustment or we've had something that happens in that time. The cost report goes, we're just trying to estimate what we think the actual contractual adjustment will be. Generally, we're pretty close. So at the end of the when the cost report is filed, it's within relatively small variance from this estimate of 23% of total revenue. And that's adjustments for whether it's Medicare or the commercial. If we have a higher adjustment, we might have more commercial or smaller adjustment, depends on. So that's where you might have some.
This is one of the main areas that kind of determines our P and L, or profit or loss for that month, because anytime we're above 23, it's very difficult for us to have a profit like that.
So one of the things that we also deal with is if it appears we have a bigger profitable month, do we want to set the contractual adjustment as a buffer? Do we want to come back to that 23%? Or do we want to say maybe to 25%? So that takes our, at the end of the year, our adjustment more accurate. How do we want to reflect it? So there's a little bit of guessing in that. There are some programs that I've been told about, I have not seen it yet, that take your cost report and calculate the Medicare payments and actually creates an accurate adjustment every month.
Is it worth it?
$5,000 versus guessing and then finding out at the end of the year.
Well, this is one of the key components of our profit and loss, is this section right here.
Right, well, that's where the variability month to month, while it's important to study, doesn't necessarily indicate that things are really great or really bad. So is it worth it to modify month to month when we know at the end of the day it's pretty darn close to that? That's the balance. Is it worth it just to say, yeah, our guesses are about right? Okay.
Just the bad debt line, you see how some of it's positive from collections and some is negative from write-offs. The bad debt is really just they have the ability to pay, but just don't want to. And the admin write-offs, those are the ones where we're cleaning up accounts and, it's past timely filing, where it's really on us. And you look at the month of July 21 and August 21, that 438 plus that 190 basically almost equals the deficit in the P&L. And that's September there.
Could you say that again?
Yeah, so for admin write-offs for the month of July 21 there, it's 438,812, and then August is 199,008. That actually equals within, I want to say $20,000 or $30,000 to what our deficit is. Yeah, and so it's unfortunate, it's just frustrating because that's why you see September's nice and clean. Honestly, it just hasn't been fully reconciled yet, but it had the highest collections ever.
Just had a little curiosity on that 15 number under February 21. Just a small number just stands out.
The 16% or 15% here, that's $15.
Admin write-offs on
February 21.
February 21,
Yeah,
15.
So here's what to keep in mind. Cheryl had left January 1st. She had directed an adjustment in December. We had January, and we did not have a replacement chief financial officer. So I hadn't been able to approve all the adjustments. And so that's why it took some time.
this 173,383, that was closing of eClinical. Susan and I worked on that. The next one was 438,812, that was Whitley doing the CPSI. And And this 190 in August, I think, was like the final cleanup of any outstanding account balances in any of the systems. So,
That's why that number was so small. And you can see it was catching up at a later date.
okay, the balance sheet, not a whole lot exciting here. Cash did increase by 1.2 million. That's, you see the days in cash on hand decreased as well. Total assets of 56.6 million, total liabilities of 47.2, fund balance of 9.3. And that's all I have for the hospital report.
I do have one thing to add. We just got, maybe an hour ago, a letter from Leanne Evans from Washington Federal. They had reviewed our debt ratio and found that we were in compliance. So I guess they're going to now more systematically provide an analysis of it. So there were some issues that they were looking at.
Okay.
And we just before the meeting got that letter. So I don't know if you saw that.
Yeah, no, I read it, and it's actually, it's kind of accepting our way, but they're saying, hey, you know, going forward, we need to look at this, and this, and just kind of compute it a little bit different way, but we're still okay. I feel like they accepted partially ours, and we had to accept partially their methodology, so. But I was happy she came around to our way. Ours is kind of more rolling so that we kind of reduce some of these peaks and valleys and make it more consistent.
Okay. That's, well, we've got a couple of resolutions here.
We do. You have those two?
Have you guys had a chance to look over those resolutions?
That I have not.
Okay.
So there's a couple things that we are looking for board approval as required by one of the companies. So we have authorized budgeted purchase of from Hillrom, which is the company that supplies us with beds, the call light system. We're using a different system right now, and it was the system we chose when we first moved into the new side of the hospital. And we thought it was a good system. We asked them, it's now time to renew and either upgrade, or at least this current system is past its life. So we asked the current company for bids. They couldn't seem to do that, and they couldn't seem to provide the kind of quality service that we would expect. We went to our bed manufacturing company. They make a product, and that's Hillrom. We think this will be a good system, correct, Teresa? We're very pleased with it. The cost of this was all in budget, and they're going to finance the purchase for us. Hillrom is.
Okay.
And so what we need is board resolution to prepare to do the financing. And so our attorney drafted up this resolution, and then there has to be a letter from a legal response saying that you've authorized this, and that we're able to go ahead with this.
If we move forward with this, when do we anticipate this would actually be installed?
Teresa, any sense of that?
I would hope by the first of the year, but I think I'm dreaming, so it's probably gonna take 6 months for all of the parts of the project. It's a pretty big project, believe it or not.
And it will fill a lot of the gaps that are challenges you're having with some of the call light.
The call lights, the nurse locating system, and this will also provide us with a system that works with that, but allows us to use phones. So we can have phone interconnection, and we can also have secure texting options.
What does a nurse locator do?
Locates the nurse.
In the hospital, but in the hospital, like where?
So when you walk down the hall, you might notice up above the doors, there's colors. And those colors tell us, is that a nurse in that room? Is that a CNA in that room? And then if they go on in the room, we can locate them on our computer. So it'll say they're in room 103 or whatever. And it also turns the call light off, so they don't have to physically walk over. Every time they walk in, they don't have to walk over, cancel the call.
Do you have that
Cancel.
feature now, I mean, locating?
We
nurses?
do, but it isn't working. It's been off and on, not working for over a year, probably closer to 2, which is one of the reasons when we looked into fixing it, we realized that our system was out of service, they weren't making the parts for it anymore, and we just can't get it, we can't fix it. So that's really been really frustrating for us.
Also, the cost, I just want you to know that from what I originally sent to the board members, the cost for this system at $331,000, there's also $104 on top of that for this Volet system that is part of the installation component. And it was $22,000 less. Now, it's $22,000 more than I originally told you. Total price is $435, $186.72. And the reason for the difference in price is because as the Hill-Rom company and the Volet system worked together, they realized they needed to do more software integration and installation. And that's what that extra cost was.
So what is Volet again?
Voltaire, I think it's Voltaire. Yeah, it's the part I mentioned with the phone system.
Oh.
Voltaire,
Mhm.
VOLATE.
I thought it was VOLTE.
Okay, anyway, Voltaire.
He's got it.
Listen, if you can't spell my name right,
Well,
you know.
honestly-
I don't have any problem with that. I recommend that you approve this resolution to acquire the Hill-Rom system. And ask that you,
I think it's needed, and I think we should approve the Hill-Rom system as the resolution that Charlie's gonna hand out to us.
Resolution 21-4.
Is that a motion?
Yes, but I'd like to see the resolution, not the resolution.
oh,
I thought you had.
I thought
Send
we
that
said this.
out.
I thought you said you changed it.
No,
No, just in the dollar,
Well, that's part of the resolution.
but the resolution. It's just the total cost, the resolution hasn't changed.
Isn't part of the resolution the total cost?
It doesn't actually describe the total cost in the resolution.
Right.
we just attached the master lease to the resolution.
So you're agreeing to the lease. And as part of that, the lease, I just wanted you to be clear that it was not from what I originally sent out, there was an addition. Unbeknownst to us and unbeknownst to them. So it kind of surprised us.
So that is my motion to accept the resolution as presented.
Second. And moved and seconded to adopt resolution 2021-4, adopt the master lease agreement. All those in favor?
Aye.
Passes unanimously.
Jen, do we need to sign this?
Yes,
Do we sign the copy we were given, or do we?
yeah, that's that's the original.
I have the second copy here, I didn't realize you had another copy.
I don't bring it up.
Okay.
And then I pass it around the time.
Okay, we're also looking at resolution 2021-5 for the purchase of real property.
Yes. Board of Directors authorized me to engage in negotiations to purchase property at 200 Birch Street. We negotiated the price, the final price came in at $225,000. And would like to ask for approval to move ahead with the resolution of that purchase.
This is something we've been working on for quite a while. Any questions?
All I can make.
Okay,
That's what we said.
resolution 2021-5.
Did you get that from Tim or what?
Yes.
And I second.
Which is real property.
And to move and seconded to adopt resolution 2021-5, purchase of real property. All those in favor?
Aye.
Passes unanimously. Okay. Yes, the EMS and vehicle.
Okay, just a couple of things.
Is Tyson joining us?
I always like for the audience to know a little bit more information on this purchase over on First Street, just for the audience. Can you just explain the purpose of the purchase, because they always question with buying property and why?
Okay, sure. One of the things that, from a strategic plan standpoint, we look for is to find properties that are near to the hospital, within walking distance if possible. Because we often have trouble finding places for either visiting doctors, physicians that we're trying to recruit, or for that matter, other individuals that we need to try and bring into the community, and they can't find a place to live. Housing is very, very tight in our community, as everyone knows. And so the purpose of this is for that purpose to put either visiting practitioners, or if someone has a hard time finding a place. And I can assure you that every single one of our recent hires of managers have struggled with finding a place to stay or to rent or to buy, for that matter, just because of this. We have lost applicants who have said, I can't find a place to stay. So that's the reason for this.
We mention that each time, we might have different audiences, and I always like to make sure that they know.
Absolutely. As an example, if you look at what is happening in Medford, granted, when the fires occurred last year, it was a significant impact, and there were a lot of employees that were living where the fires occurred and lost their homes. Working with the town, the regional medical center, Sante Hospital, across the street from them, established a mobile home park, and they have had employees living in that mobile home park because they had no other place to live. Their houses had burned down. They continue to have that for either visiting, traveling, itinerant workers of any kind, and it stays very, very busy. It's
Well, we
very
helps our recruitment, I'm sure.
Tremendously, yeah.
so.
And that's what
That's
we
the
need
reason
for our
why.
recruitment as well.
Yeah, so we have probably lost over the last year, I'm going to say upwards of between 9 and 10 candidates because they could not find a place to live. We do everything we can to work with community who have rentals and places for sale. But there's issues of people have pets, maybe they have quite a few kids and what's offered is not big enough for them. So there's quite a few barriers, or maybe it's too far out of town. So we definitely need to really be conscious and look at housing opportunities for us here.
Thank you, Lou.
Sure.
Okay,
Just an update on other purchases, it's not, these are within our budget, but wanted you to know that we are purchasing a replacement for our mammography equipment. It has reached its life expectancy. The new machine is a 3D mammography. Cost for this is about $324,000, and it will be financing this. But this will be a great improvement for the service, this vital service that we offer. So that is a purchase that we have made. We have in budget to replace some of our vehicles that are in our fleet. One we will be replacing sooner than we expected because of an automobile accident that one was in yesterday, or is it Tuesday. And then we will also be replacing the transport vehicle that we have for our medical supply company. It had It has well reached its life expectancy, and so we'll be purchasing that. We were able to negotiate fleet rates with Ford, so that'll enable us to continue using good vehicles and working with Walmart. So I did look into a question that Don raised, and that was, what about electric vehicles? And what we find is in our medical supply company, as we are hauling things around, very frequently we would exceed 400 miles a day. And you have a vehicle limitation because of the electric batteries. You can't go that far in the time to charge would make it not as convenient. We looked at a diesel, but that would have cost us an additional $20,000 just for pricing. So when we buy these vehicles, we put a lot of miles on them. And it is really astounding how much money it saves the district by doing this, rather than paying people to drive their own.
Oh, yeah. Okay,
That's all I have, sorry.
that was on the EMS vehicle lease.
So on the EMS vehicle lease, we presented to the disaster unit initially purchase option to buy at the fair market value, the vehicles that they had. But on second thinking, we offered them the option of continuing their existing lease for $1 for another year. We have not had a response back from the disaster unit, so I'm not sure exactly if they've accepted our request. So I don't have an update. And unfortunately, while the disaster unit, I think, met as a board, we did not get any official notice from them. I don't, as far as I know, we're still paying $1.
Thank you, Dave. Okay, Ed, Goose Lake Medical Services.
Okay, so this one has a lot of slides just because we went in to do the budget with the Goose Lake board yesterday. Lakeview Gardens FY22 budget is based on the FY21 actuals, but then also taking into consideration on the revenue side some improvements that we've made to be more diligent. The write-offs about proportionate. The really big changes here, and I tried to make this more legible than showing the difference that we did yesterday. But contract labor going down based on the education classes that are, going through the facility here. That really makes a big difference. It's about $20,000 a month when we can use the, between contract labor and the permanent employees, so that's that adjustment. Everything else, the things that aren't in here that are still up for discussion, I think, is we talked about reopening the kitchens inside the homes and whatnot. That's we have to get more detail as far as that cost. Right now, they're eating out of this kitchen, and
So we started with using each building in its own kitchen, and then we changed that to
centralized because of the
I think
staffing and
assisted living, aren't they cooking in there?
So they do. So when we designed the buildings, the plan was that each house would make their own food. And the reason for that is as people get older, often one of the things that happens is they lose their interest in eating. And so studies have found that if they smell the cooking, they develop an appetite and want to eat healthy food. We ran into a problem with the interest of the staff, or the interest of staff to do the work, to cook and to care for the patient. So what we found was our quality was not able to stay at the standard that it needed to be. So we brought the cooking back into the health district where we could control the heat, temperature, quality of the food, have consistent. We do make items that would be aromatic. We make cookies, we make cakes, we make some sort of special things in each of the houses to try and encourage people to want to eat and to celebrate being in their home. Again, the concept of each of the houses, that it is like a home, not an institution. So, but we look at, can we save money by actually having everything? And can we deliver as good of a product? So far, we have not found that we could do both in an economical way, but that's still an option.
Part of that making.
That'll get rid of all vegetarians or convert them.
Okay, this is a P&L statement for Lakeview Gardens, for the month of August was revenue was 268, expenses of 434, resulted in a deficit of 148. You see that contract labor thing is the backbreaker for us, and it spikes up in August because, you know, we had a lot of employees, COVID and whatnot, other issues that arose out of our control. Just destroyed my projection. But, this just kind of went more into detail on the revenue and how it was trending year over year. And honestly, the last 2 years, there really haven't been much way to predict things with the pandemic, so that's more just for informational. This is the patient days. So you see the top, the highlighted is that's actually 2022, where down below is actually 2021, prior year. So
You mean the bottom two lines are 2021?
yes. Yeah. So and it's based on long-term care up top and assisted living down the bottom. As far as patient days, the difference between last year and this year in long-term care, about 44 patient days.
We have a waiting list in assisted living.
We do not.
And you see the 11% increase. Now Lake Health Medical Supply. So their FY22 budget has a lot of different things going on. It's got about 10% more in revenue, based on their experience and just the way they're tracking right now. So far, the expenses that changed, the other expenses you would see was 83,426. It went down to 30. So that cuts out the consultants and the legal and the rent and anything else that's not occurring any longer. So they haven't projected out at 105 net income. Based on their P&L so far, they're going to exceed that. They run a pretty tight ship over there. And, I think they're,
Well, it's nice to see the positive.
yeah.
Are
They're
we liking
expanding.
the new digs?
Yes, very much so. And they just had a survey too, and did awesome, so.
Talked about that last.
Is that like an inspection?
Yeah. As a balance sheet, I showed this just to kind of get the buy-in that they do have, you know, 444,000 in cash. This is their current van. It's a 2011 Ford Transit Connect. It's got over 200,000 miles on it. And, you know, some of the larger items, it doesn't make it very feasible. This is the replacement van. It's an actual Ford 2022 because truthfully we couldn't find any within 2,000 miles that was used or in any kind of serviceable condition. They're just all sold out. So it was easier to go through Hall and get on the Ford Fleet program and order this.
And it is all-wheel drive.
Yes, and it is single back wheels, not the duals.
Oh.
So we checked on that today.
Oh, you did?
Yeah.
Okay.
But it still has the difference. I think it's like 2,000 gross vehicle cargo on the smaller one, and that has about 20,000. So they can carry a lot more bottles of oxygen, concentrators and whatnot.
So the 20,000 is for the single back wheels, not for the duals.
Correct. I think the dualies are rated like 30,000 or something like that, or 25 or 30.
Well, this is still lower capacity than the.
Correct. And we're never gonna haul that kind of weight. But you couldn't, the smaller vehicle, just, it's got to where we're hauling much more stuff than we do. And that's a good thing.
That's all I had.
Is that it, Ed?
That's it.
Thank you, sir. Any other questions for it? Dr. Foster is not here, medical staff privileging, I saw like 2 or 3. Two.
So, Dr. Foster apologizes, he's not feeling well this evening. And so the 2 applications that the board, or that the medical staff met and approved. One is for Amy Thiel as a psychiatric nurse practitioner. And Travis Abel, who was a reappointment for consulting medical staff as a radiologist. Both were approved and approved by the medical staff, recommend that the board approve their applications.
I so, move to approve the application of the 2 mentioned, staffing.
Medical staff privilege.
Yeah, medical staff privileges.
And moved and seconded to approve the medical staff privileging as presented. All those in favor? Aye. Passes unanimously. Okay, Teresa, you're up.
Well, I'm speaking to you from the halls of COVID land. We've had quite a lot of patients the last couple weeks. So it's been challenging for the nursing staff and tough on, the people going through it. So hopefully we'll see it
Did
down.
we get close to capacity?
Well, we're certainly handling more COVID patients and, than we would like. Luckily, our maintenance department is so capable of turning the rooms into negative pressure that we're able to use more rooms than the ones that were built that way. So we only have 2 rooms on the floor that are negative pressure. So our maintenance staff helps us with that. So that we can have negative pressure and isolation rooms for those other patients. So people are
How many rooms then
right now.
for negative pressure?
We have 2 standard set up, and then right now we probably have like around 7
Okay,
set up. So, people are coming in for the regenron infusions, which help them fight the infection. So we have a lot of that going on.
Can they do that on the outpatient basis?
And they do that as an outpatient, so we have a room set up for that. Because they have COVID, so they're, infectious. And then we do have, people suffering from the effects, even though they're out of the acute cycle, they still have some effects from it. So it has been a challenge, and, it's an ongoing thing. I hope we get over the peak soon. As far as other things, we have several staff members thinking about making changes, so that always presents a challenge because we'll be needing to replace nurses in the relatively near future. We do have our new cardiopulmonary department manager here and working, and she's doing a fabulous job, and I think that department will see an increase in some of the testing that we do and some of the processes that we have, just because of her knowledge. So I'm excited about that addition.
Where does she come from?
She actually lives in Sprague River. So she comes over during the week and then goes back on the weekends.
Prior to that, I think she was in Kaiser, wasn't she?
I can't honestly tell you all the places she's been. I feel like she was at Salem, and she was at, I can't think of it. It's a little small hospital. Ooh,
But you've been over on the west side.
yeah. I forget the name of the town, it's a smaller town. Anyway, yeah, so that's great. Great news for us. So, any questions for me?
Does the regenron really work?
You know, it's funny, I had somebody tell me just this past week that she had that infusion. She said, I almost felt like, that I was just being like rejuvenated and I was just turning into I'm fighting now kind of a feeling. She actually felt the difference. Within 24 hours, she felt a big difference, so.
And we just started that in the last couple of weeks.
No, we've been doing it for quite a while. I can't tell you how long.
Now, what type of infusion is that?
It's, monoclonal antibodies, so it helps the person's body sort of coat the virus and helps you fight it more effectively.
It's an antibody that binds to the virus.
Is that typical for an antibody to bond with a virus?
Well, yes,
That's what.
it is typical for a person's own antibiotics, but these are
Synthetic.
synthetic, thank you.
Thank you, Teresa. Anything else? Okay. Glad you guys are down there and hanging in there. Let's hope that COVID goes down a little bit. Mr. Twain, CEO report.
As always, there's a lot going on. Certainly COVID takes so much of our time, and it's really amazing what all of our employees, all of our healthcare workers have done in dealing with this. It's stressful, and it's sometimes it feels like it's just hard to handle the stress of this. It is ongoing. We're facing a time now where OHSU, as an example, is predicting that this level of care and the overwhelming status of a lot of the hospitals in Oregon is going to last through the end of the year. So, it's just truly amazing how resilient our staff is, even when it is difficult. It's hard, and they do a fabulous job.
I much appreciate it.
It is really. Some days it's not as easy, so we often forget that there are other positive days too. Probably the most important thing for us to think about amongst all the positive things that are going on is the issue about how are we going to deal with the vaccine mandate that the governor has established. And as of October 18, everyone has to either have been vaccinated, fully vaccinated, or have signed an exemptions form to be able to continue working on October 19. We've been tracking that and trying to talk with members, helping explain what it means, what are the risks, what are the concerns. Many people have lots of questions. You heard a couple of meetings ago, the concerns raised by employees. As of today, about 50% of our employed workforce has been vaccinated. About 28% have signed exemptions, and about 22% have not, or we don't have enough information. Sometimes our systems don't track it as clearly. Some of the individuals are very part-time, some are on the fence. So we don't know exactly where we stand. We do look to see by department who might possibly not sign an exemption, because if they haven't gotten vaccinated, we don't have proof of that. They have passed that time when the state views them as fully vaccinated. So that was on October 4th, Monday.
Even if they had the Johnson & Johnson one shot,
That was, they had to have gotten that by Monday.
oh, to have the 2 weeks.
Correct. To be, what is determined to be fully vaccinated. Now, it's possible there might be adjustments between now and the 18th, I don't know. But we have to plan and act as though there aren't any changes. So of that 22%, we will continue to ask and plead to,
So someone who is late in getting a vaccination, say they get it next week, and it's the J&J vaccination, they can't work after the 18th, but they can come back in November.
that's true. They could also sign an exemption form between now and then they could continue to work. What's also an important date to understand is that as of October 19 going forward, anyone we hire, they will either have to be fully vaccinated or sign an exemption for them to start working. Because the requirement is, as of October 19, all healthcare workers have to have done one or the other. So we'll be tracking that. If we don't have that, those people will not be able to work, or we would be fined $1,000 a day. So $500 to the employer and $500 a day to the employee. The probability that an employee would pay that is probably nil. So we would be fined. My hope is that we will be able to not lose any employees, although we've already had some people that have moved on and have chosen to work elsewhere because they didn't want to do either of these two options. We might have some people retire early because they choose not to address this.
Of the 22% or thereabouts, do we know what departments are of critical concern?
We do. And at this juncture, all the critical departments would be covered. So we would not have to shut down a department. There have been hospitals that have talked about they might have to close their OB department. They may have to, OHSU announced that they might have to close one of their units at the hospital. Another hospital talked about unless people sign, they may struggle with having housekeeping, EVS. And people have options to work elsewhere. So it's certainly an issue that we are concerned with. We're doing all that we can to ensure that we stay open and we continue to provide the care that we need to our public. So that number, we hope to be able to, as it changes, if you're interested, we can provide you updates. But we'll continue to provide that, to get that information. Understand that all exemptions are provided to Rebecca or her team, that they are on file, they are not available to the Oregon Health Authority or anybody else. I don't need to know what's on those, and I don't need to know. All we need to be able to answer is that we have on file that information. So, any questions about vaccination and vaccine mandate issues? Okay. We did sign an agreement with the Teamsters to deal with this vaccine mandate that was negotiated. We are in negotiations with the Oregon Nurses Association members and hope to resolve that. They gave me their proposal yesterday, so we are trying to work through some of those.
Speaking of the Teamsters, we reached an agreement on monthly.
So there are some issues outside of the law that they wanted to have in an agreement. As an example, one of the features that they wanted to know is if a person on the 19th chose not to do either, would they be placed on administrative leave rather than sever their relationship with the organization? If they did that, how long would that administrative leave be? And during that time period, would we guarantee that they would be able to come back to their job if they either got vaccinated or signed an exemption? So we negotiate on that issue, those issues. The Oregon Nurses Association has some similar kinds of requests. We're in the process of dealing with and addressing. Hopefully we'll have that resolved. Right? When Ed talked about surveys, we have had several in the last, since the last board meeting. When we talked about surveys, we get either surveyed or members of various organizations come to ensure that we are delivering appropriate services.
Survey is what you call an inspection.
It is an inspection.
An audit.
It's an audit. So besides the medical supply company inspection, we were, the radiology department was surveyed, and we were found to be an excellent, no write-ups of any kind. The Alturas Clinic today had its inspection by, or survey, by the CCO, if you will, the Medicaid contracting entity, Pacific Partnership Health Plan. We came out with 92 and 93%, so no write-ups of any kind. A couple things we had to provide, but that came out excellent. And we had our long-term care because of COVID and because of staffing, and they wanted to validate our staffing rates, and that came out without any problems. That was also today. So it's an ongoing, it's not that we don't have these frequently, but the results, everyone is checking to make sure we are doing what we say we're doing.
Shows the team's doing pretty good.
They're doing fabulous.
Question on the long-term care and visiting surveyors. Do they go into the premise to do their survey?
Absolutely. Absolutely.
Are they concerned about?
Fully vaccinated?
Yeah.
They have to. Yes. And they're masked and they're properly protected and wear face shields just as required.
I assume.
Couple, we did have a separation with our executive director for mental health. And Heidi Martinez is our interim director. We have posted the position and we're looking for filling that position in as near a future as we can. We should have our final interviews for our clinics director position next week, and we'll be able to make a decision on that. Oftentimes, it takes time to find replacements. So we'll keep working on that. We have just opened up phase 4 of the monies from the federal government. There's approximately $25.5 billion will be available to rural and others to deal with COVID. That came up October, well, it started just this week, or was it last week?
Last Tuesday.
Last Tuesday, and we have a window through, I think it's October 25th, 26th, to apply for that. There will be about $8.5 billion specifically earmarked for rural, and about $17 billion for provider relief funds.
And
All these
that's
dollars.
national.
Pardon me?
That's national.
Yes.
That's Lakeview.
If we could only get it for Lakeview, we'd be happy.
I wanted to make sure it wasn't state or region.
Okay.
National.
No, this is on a national basis. We don't know how much will be available to us. It'll be in part based on how many people apply. And then there's also some criteria that they'll be using based on the claims that we have submitted. So some past history and as well as some lost revenue.
So the restrictions on what we spend it on, they could buy the van for the EMS.
There are lots of possibilities. There's lots of education coming out about how we'll be able to use the money. Some of it we'll be able to use it through the end of '22. Some of it, I mean, it's a complicated market. But we'll be applying for that, and we'll tell you how much we get when we know.
Okay.
Money will be coming in the first tranche in November and the second in December. That's what we know today. We also received today, or it was yesterday, a notice from the Eastern Oregon CCO that we will be receiving our withhold dollars and an additional bonus dollars of $743,000. So this has been a good year for the CCO. There's been an increase in the number of recipients in the Medicaid program as part of the expansion. And the organization has managed its dollars well, and so we have been recipients.
How much do we have in the budget, do you know?
We never know, so we can't budget. Last year, there wasn't any monies distributed. We got our withhold, but we did not get any additional money. So this is a nice amount. It is reflective. The CCO had about $30 million that it distributed. Our portion is equivalent on a percentage-wise basis to our percentage of the population of the CCO, which is about 2%. So it's in line with the membership. Keep in mind that 75% of the membership is in Hermiston, Pendleton, LeGrand, Ontario, those areas, because that's where the population is.
Can we argue just for a minute? Population is person to person, but we still have the same administrative costs that we might be able to argue for a little bit more.
We argue as often as we can. One of the things that does impact that decision-making process is those communities, those hospitals are part owners of the CCO. So the CCO is owned 25% by Moody, 25% owned by Gobi. Each of those, the 4 hospitals that are larger in those communities, Hermiston, Pendleton, LeGrand, and Ontario, own each 10%. And the remainder is owned by some physician-owned clinics that are in Eastern Oregon. And that's the makeup of the ownership. And that's where the business really is. The other 25%, not the 75%, the other 25% is spread between Lake County, Hardy, Grant, Wallowa, and where Heppner is, which is,
So Deschutes County's not in this.
no, Deschutes, Crook, and Jefferson are in their own CCO. So this population is from essentially, not quite the Dalles, all the way around to Blythe and east to the Oregon border, to the Idaho border.
Okay.
Okay. Those are my comments that I have, unless you have questions of me.
Any questions?
Charlie, did you want to mention the CRNA?
Yes, I can mention that. So our certified registered nurse anesthetists, we have 2 CRNAs. And both have submitted their resignation. Several months ago, we have been in the process of searching for replacements. We have one that we have signed an agreement with, we have a couple that we're working on, and we're now locums to handle the volume until we get the others on full-time. So we're working through that process. Is that what you have? I know we've talked about this, it's a very expensive process.
It's a frustrating process.
And that too.
Okay, well, we'll go into,
Before you do that, Rebecca, did you have anything you wanted to ask?
No, I can't think of anything, but thank you.
I'm sorry, I should
That's okay.
just slap me a couple times. I'm busy. Okay. We'll go into executive session under ORS 192.660, bracketed 2, bracketed A, personnel, bracketed C, medical staff, bracketed E, real estate, and bracketed H, legal. And we'll take a 5-minute break.